Oce, noswaith da pawb. Good evening, everyone. Ar athro Oliver Turnbull dwi. Croeso I Prifysgol Bangor. Welcome to Bangor University. It's a pleasure for me to be here. I am, as the Deputy Vice-Chancellor of the University, here to stand in for my boss, the Vice-Chancellor, Professor Edmund Barke, and here to introduce this evening's distinguished alumnus, Professor Edmund Sonuga Barke, which means that I'm representing Edmund Barke here to welcome Edmund Barke. The VC is on the way to Cardiff at the moment, so please don't be worried that there isn't some rule that the two Edmunds can't be in a room at the same time. But also really for me a particular pleasure here as a psychologist to have an opportunity to welcome our very distinguished speaker, a professor of developmental psychology, psychiatry and neuroscience at King's College. He has a substantial role at the Maudsley in London, a fellow of the Academy of Medical Sciences, the British Academy, a number of other influential roles, including editorial roles in prestigious journals. He also, of course, as I'm sure he'll say a little bit more in a few minutes, is an alumnus of this wonderful university. I won't tread on his toes by saying too much about that, but I'm sure there's much that he can say. And of course has been a real pioneer in ADHD in many of its manifestations, I think, for several decades. So without any further ado, we're in for a really thought-provoking talk, and I'd like us to give a round of applause to our wonderful speaker here this evening. Diolch yn fawr iawn.
Thank you so much. Can everybody hear? Can you hear at the back? Yeah. It's great. Thank you very much. Good evening, everyone. Thank you, Oliver, for such a kind introduction. I am delighted and deeply honoured to be here to celebrate the 140th anniversary of this wonderful institution, my alma mater. The main purpose of today's talk is to tell you a little bit about the scientific progress we've made in understanding ADHD and how that progress is forcing a fundamental re-evaluation of the ADHD concept. However, I think to help you understand my contribution to that process and the key role that Bangor University played in that contribution, you probably need to know something about how I ended up here in Bangor and the transformative effect that being here had on my life. So how did Eddie Barke, which is what I was called in 1981, become Edmund Sonuga Barke? I thought it'd be quite fun to formulate this as a developmental path model. So here he is, the originating cause of this chain of events. Great genes, half Irish, half English, great environment, growing up in a Roman Catholic faith, in a loving family, in a strong Irish parish of St Mary's in Derby, the jewel in the crown of industrial England, of course. But despite these wonderful advantages, the first pathway is quite easy to draw in. So Eddie Barke was an abject school failure. Why was school such a disaster for him? Well, there are two mediating pathways in this first part of the model. One cognitive and one motivational. You'll see I like multiple pathway models, so this kind of fits in very well with my own work. So the cognitive pathway, I'd say it's mediated, but what you might call my love-hate relationship with language and words. Now, I loved language and words when they came out of my mouth, and they did nearly all the time wherever I was, whether I was in a classroom, whether I was in assembly, whether I was in church. And that meant, of course, I got into a lot of trouble. I spent more time outside the classroom, waiting to be punished, than actually inside the classroom. I hated language and words when people wrote them down and I had to read them. Or I wrote them down and I had to spell them. Now, people call that now dyslexia. In the days when I was at school, they had a different word for it. My motivational pathway, I would call it probably mediated by something like task avoidance, because I spent nearly all my time trying to avoid doing any schoolwork if I could possibly help it. And my teachers also, they had a technical term for that as well. But, you know, that task avoidance had some interesting secondary consequences. So it's not a very well-kept secret, but I was the founding member of the very greatest punk rock band in the Midlands, Antipasti. There's two of my other founding members, Dougie Bello, I went to school with, and Martin Roper, who lived round the corner. And for those of you who weren't exposed to the joys of punk rock in the 1970s, I thought we'd give you a little taster of the first EP. And you can sing along if you know the lyrics. I thought you'd like that. In Wikipedia, they say Antipasti were a commercially successful but critically reviled second-generation punk rock band. Unfortunately, when I left, after about a year at the age of 17, they were just critically reviled. So critically reviled, abject school failure, things didn't look too good for me when I left school. So I can see the developmental psychopathologist so much you're thinking, I know what this lad needs, he needs a turning point. And my turning point, number one, came when a wonderful lady in Derby, Mrs. Marr, who dyslexic herself, she ran the Derby Dyslexia. She started the Derby Dyslexia Centre, but she also knew Tim Miles. And of course, Tim, from here in Bangor, was a pioneer of dyslexia research, looking to develop a more enlightened and more scientific approach to dyslexia. But he also had a scheme, and I don't know how formalised it was, because Tim was a maverick. But he worked with Senate to each year allow a couple of kids who'd failed at school because of their dyslexia to get places on the psychology degree. So I came up here into the top of College Road, you know, the loft in the College Road building there, did the dyslexia tests again with Tim and IQ and all that, and he offered me a place. But he said the condition was you had to get 2 A levels, E grade. So I just had to matriculate to come in. So you can, and I did just about manage to scrape 2 A levels when I went back to technical college and redid my A levels. And so this was gave me a university education, which I wasn't expecting at that time, obviously. I thought I was going to be a pop star. No, I don't think I was going to be a pop star. But more than that, it gave me an intellectual formation, because not only was an opportunity to study for a degree, it was an opportunity to study for a degree here. And this was quite a special place in those days. It was 7 or 8 lecturers, but they were all very passionate about ideas and creativity. I mean, there was Tim himself, more a philosopher probably than a psychologist, and he taught me to distinguish conceptual issues from empirical issues. Always get your concepts sorted out first, then try and address the empirical questions. And I've never forgotten that, and I've always been, trying to follow that through in my own research. Then, of course, there was Fergus. Of course, both sadly not with us anymore. But Fergus was probably the only radical behaviourist Skinnerian in the UK at the time. And of course, Skinner has written a lot of rubbish, but he also wrote some great stuff. And his focus on function of an action when you're trying to explain its existence really stuck with me. So don't focus on the form, focus on the function. And he even termed a thing called the formalistic fallacy, that you look at the form rather than the function of a behaviour. And then we have Nick Ellis. So Nick is a distinguished professor of cognitive psychology somewhere in America now, Michigan, I think. But anyway, he was a new lecturer when I came, and he was my personal tutor. And Nick was so passionate about what he did. And I experienced this at first hand, because I was chattering away at the back of his lecture, and there was a kind of a deep intake of breath from all the people in the lecture room, and then a board rubber flew past my ear. And I was quite used to that from school, so I was very good at dodging it. But it left a psychological impact on me, certainly, of how much he really cared about his work. 2 other people I'd like to mention, my PhD supervisors in Exeter, obviously I went there after I finished here. Paul Webley, again, sadly lost far too young. Ended up actually as a principal of SOAS in London, but he was my supervisor. And he taught me, when you're thinking to understand children's behaviour, take the child's point of view. Kind of makes sense. And then, of course, Stephen Lee, the great behavioural economist, was my other supervisor. And he really taught me about the idea that actions are really have to be understood in the context of the other opportunities and options available in an environment. So I had a scientific orientation. I didn't probably know it. I probably couldn't have expressed it like that. But it was really kind of that intellectual formation I got here in Exeter. And I was then, of course, looking what to do. So my second great turning point was coming across this gentleman, also a pioneer, but this time in ADHD. This is Professor Eric Taylor, really the main pioneer in the UK in ADHD, or as he called it, in hyperkinetic disorder. And I applied for a job with Eric, so I assumed there weren't any other candidates because I got it. And then I worked with him for a couple of years, but he's been my mentor really ever since. Now that was in 1987 after my PhD. And since then, of course, I've worked in the field of ADHD, trying to crack the ADHD code, along with an increasing number of other people around the world. So that I don't know what it is. What is it? I can't think what it is. 35 years? I'm not sure exactly. I don't like to think. Has been quite an adventure. Ingenious designs, exploitation of new technologies, collaborative working, and increasingly big data analytics. That's obviously the big deal now. And at the heart of that journey, though, is a real paradox. How can we have come so far in our understanding of ADHD on that journey and yet feel further away from the destination than when we started 30 years ago? Now, it's not because the destination's changed, because our goal is still to understand ADHD so that we can then develop new interventions to help people with ADHD. I think the solution to the paradox is actually that the roadmap's changed. And it's the science and culture that's changed the roadmap. It's much longer than we thought it was going to be. We sort of thought it would end up about here, and I think, it's out the building, really, the destination. And it's all much more circuitous than we thought it was going to be, much more complex than we thought it was going to be, but actually much more interesting too. So, in terms of ADHD, considering ADHD as a thing to treat, and therefore a thing to study, starts with the realization that extremes of inattention, hyperactive and impulsive behavior cluster together to undermine a child or an adult's functioning, that creates distress for them and for others, and has a negative impact across their lifespan. Now, you can look at that pattern of behaviours and the pattern of impacts in lots of different ways. But I think it's pretty obvious, self-evident really, that the lens through which we've looked at this is the so-called medical model, traditionally in the field of ADHD. And that's been a mixed blessing, I would say. Certainly it's given us a valid and more or less reliable diagnostic system that has been essential for scientific progress, and has also increased access to evidence-based treatments, particularly medication, which I think it has been a plus side of the medical model. And I'm going to talk about some of the other side of it probably now as well. So in terms of the diagnostic formulation in which the medical model is sort of embodied, it starts with this bloke, this paediatrician, Sir George Still, which I always think is a great name for somebody doing work on hyperactivity. He had a good sense of humour anyway. And he coined this term disorder of moral control. Now, obviously, the language is Victorian. It was the late Victorian period. But it captured it, in behaviourally and in terms of the symptom profile, it was pretty much like ADHD. Then there was a kind of focus on the behaviour, the activity side with this concept of hyperkinetic disorder, And in 1968, the DSM, the Diagnostic Statistical Manual, introduced the concept of hyperkinetic reaction of childhood, so hyperkinetic syndrome. Then there was a sort of switch, I guess, with the cognitive revolution. The switch focused more on attention. So you got this more balanced profile of attention deficit attention deficit disorder with or without hyperactivity. And 87, the famous DSM-3R, you got the ADHD comes to its kind of full manifestation. And the most recent formulation, DSM-5, pretty much the same actually as the one in 1987. But now we have an adult-specific set of definitions, which is quite an important step forward, perhaps. In terms of core symptoms, I've already mentioned inattention. Here are some examples. There are 9 inattention symptoms, 6 hyperactivity symptoms, and 3 impulsivity symptoms. They're just examples of those. In terms of the diagnostic, to make the diagnosis, obviously it's not just looking at the number of symptoms, it's actually a complex clinical decision-making task. Obviously there's issue of symptoms. It's a binary, you've got it or you've not got it, and you need a certain number of symptoms, inattention, and hyperactivity and impulsivity. But a crucial element, that needs to be impairing. So it needs to impact your daily life as a person, perhaps across multiple domains of functioning. It needs to be expressed pervasively, so not just at home or not just at school. So it's not context specific. That's the idea, at least, or I'm not sure how well that works. And then, of course, it's got to be persistent. So it has a childhood onset. Now that's defined as before the age of 12, whereas used to be, I think, before the age of 7. So the age of 12. So they're loosening up that little bit. Estimated prevalence about 5%, although the actual number of people who get diagnosed varies enormously from country to country and even region to region. And there's a massive problem, obviously, in the UK. The NHS waiting lists are very, very long now. And so, like 2 or 3 years, I think the SLAM, where I am, Maudsley, I think it's 3.5 years. I mean, it's pretty shameful, actually. But as well as giving us this structure for diagnosis, it's important to recognise that the medical model also provides that set of assumptions, a stable set of assumptions that allows us to do science. And of course it was this gentleman, one of 2 philosophers of science most people know, is Thomas Kuhn. I call him the paradigm shift guy. So he was the first person to say that to make scientific progress, you needed to have a stable set of assumptions on which you could build your hypotheses. And those assumptions provide the shared concepts that allow communication. That's crucial, obviously. Scientists to talk with other scientists, and then in practical sciences to talk with clinicians and patients and so forth. So you've got the shared concepts that we all agree to, but at the same time, those shared concepts constrain our theories. They constrain what's an acceptable question or a meaningful question to address. And hopefully I'll explain that a little bit more in terms of the next section. But because it's paradigmatic, because it rests on these stable assumptions, progress is non-linear. So you have these periods of like normal, what you call normal science, where things are progressing nicely within the stable framework of values. Then you have a period of crisis. And in Kuhn's notion, that leads to a paradigm shift. The evidence comes so strong against the paradigm, the existing paradigm, that you have to move to a new paradigm. And that's how science moves forward, according to Thomas Kuhn. And that's what the medical model's provided for us. It's provided that stable set of assumptions about what ADHD is that's allowed us to progress so far in many ways. But the question is, are we ripe now for a Kuhnian revolution in ADHD science and practice? And in translational science, those shifts, those revolutions occur for, I think, 3 reasons. Slightly different in the hard sciences, because obviously not so interested in therapy or props culture. But in terms of, the first one, I think, is the fact it's just not been very productive in terms of giving us new therapeutic options. So there hasn't been innovation therapeutically within the paradigm or as a result of the paradigm. Secondly is about scientific credibility. So the paradigm basically, the assumptions, just irreconcilable with the data that's coming out of the labs. And thirdly, cultural change. And the paradigm may just no longer be compatible with societal values and beliefs. So I think all those three play into the field of ADHD. That's why the title of my talk was, I can't remember what it was now, Medicine, some Society and Science. That was it, something like that. So I think those three capture the reasons why a paradigm might shift, why a paradigm might be challenged. So what about the translational value of the disorder paradigm? Well, let's look at ADHD therapeutics. They've not changed really for 40 years, 50 years, I don't know, 30, 50 years. They still rest on psychostimulant medication, or, well, on some occasions, non-stimulant medication, as a pragmatic means of short-term symptom control, and is very effective. Hundreds, if not thousands, of randomized controlled trials showing the efficacy of Ritalin-related medications, methylphenidate-related medications, in terms of symptom control, reducing ADHD, helping focus and concentration. I don't think that's up for debate anymore. But of course there are limitations. Symptom control is partial. We don't get normalization. Some people don't benefit. A number of key impairments aren't improved. So, for instance, we've done some trials on academic achievement. Medication has very limited effects on academic achievement, which is very surprising, perhaps, and interesting. Long-term benefits are uncertain. Hard to measure long-term benefits, but the data coming out of a number of studies suggests they really are hard to pull out from the effect of lots of other factors. I'll move on. Side effects are frequent, but relatively mild and manageable. Serious side effects are very rare. And of course, medication is unacceptable to some patients, to some parents, to some clinicians, and to some countries. So, for instance, Italy and Sweden and so forth are the range of medications available is very limited. Psychological interventions have been tried for ADHD. Parent training has been tried. And while it's good for lots of things, it isn't good for controlling ADHD symptoms. So the development of effective alternatives to medication is really important. And so the approach we want to take is a translational science approach. That is, to use science to identify the causes so we can target those causes with new treatments. That's a translational science imperative that the field, I suppose, is trying to follow. And what's the translational logic in the medical model, in this model? So it starts with the notion that brain dysfunction causes disorder that creates impairment. So that's the kind of basic model. And in therapeutic terms, you want to target those underlying dysfunctions to fix them, to reduce disorder, and to resolve impairment. So that's the sort of logic of the medical model. Sorry, TX means treatment, what A and B, sorry. But let's have a reality check on this. Has this model produced any translational wins? Neurotherapeutics. So what about interventions that target the brain? So we've had those. We've got cognitive training, and this tries to strengthen brain networks through sort of scaffolded and structured, often computer-based activity. Neurofeedback. So this works by trying to regulate the brain through visualization and reinforcement. They sound great, and they make loads of sense scientifically and translationally. They're plausible. The problem is our reviews in the European ADHD Guidelines group showed that they don't actually work. It's quite clear the effect sizes are almost zero when you look at reasonably blinded trials. So why such little progress in ADHD therapeutics? Could it be that the assumptions in the disorder model actually don't match up against the fundamental nature of ADHD? And so then they're sort of blocking progress to more therapeutic innovation. So that brings us on to the second thing about scientific credibility. And let's look at 4 assumptions within the model. Some are kind of primary, some are kind of secondary. That ADHD is a natural category. Well, the reality might be that it's actually a dimension, and that actually it's not very discrete. It overlaps with lots of other conditions like autism or like even depression and anxiety. The notion that it's the core is a neurocognitive deficit. Well, there is a core role. Is there a core role, should say? Is there a core role for motivation in ADHD? That it's a singular biological entity. Well, actually, is it actually not a more neurobiologically heterogeneous condition with multiple subgroups and multiple pathways? And that it's congenital, present at birth, and that it neurodevelopmental, it sort of unfolds over time from that period. And the data and the evidence against that would be that it has postnatal origins and that there is an adult onset version of ADHD. No evidence in childhood, just an adult onset. I don't have time to go into all of these, although we can talk about them all later, but I'm going to just pick on the ones that I've highlighted. So the first challenge, is ADHD actually a dimension and not a category? So we know in any population, including this room, by the way, not to be too personal, there are a small number of individuals with ADHD. Some will have extreme expression, some will have subclinical levels of various degrees. There is obviously a continuum of ADHD at that level, self-evident. But of course the disorder paradigm assumes that that continuum, the apparent continuum, actually hides a natural category of ADHD that separates people with ADHD from the rest of the population in some way. But what evidence would support that? To do this, we look at the taxon hunter or the natural category hunter himself, Paul Meehl. He spent his whole life trying to work out how to identify these natural categories in psychiatric conditions. I think most of his work was on psychosis, but you can apply his techniques to ADHD. He argued that the only rational basis for inferring the existence of what he called a taxon, or a natural category, must lie with the pattern displayed by the presented indicators of that natural category. Or in the terms for today, look for a step change in the pattern of ADHD in relation to its underlying causes as you move further along the severity continuum. And hopefully it'll be around the diagnostic threshold somewhere. So here's an example of a bimodal distribution, kind of suggesting that there might be something discrete going on at the end of your distribution. This represents the number of individuals affected at a particular level of severity. So obviously you get more severe, less individuals are affected by ADHD, or less present. So that's the assumption that that's a natural category. But Meehl says it's not actually about the distribution, it's about that step change in the association with causal factors. In particular, brain correlates in this case, let's focus on. So this is a little bit exaggerated, I don't think you'd ever see this, but you can see a step change in underlying cognitive difficulties that occurs in those people in that hump, in that little second part of the biomode. So that's what Meehl's looking for. And he developed this, so not only was he a philosopher, great thinker, he was also a statistician, and he developed a whole battery of things called taxometrics. And these taxometrics aim to search for category boundaries in continuous data. And so what he did was he simulated what a category might look like. I can't point there. Oh, can I point here and go on there? No. Okay, sorry. So he simulated, so if you look at the one that says category, step change, he simulated what it would look like, kind of mathematical simulation, and he simulated what a dimension would look like, and then he compared it to the actual data. And you can see that with the category where there's a step change in his taxometric output, there's that little hump, the little increase in the association between the underlying factor and symptoms. And you can see with the actual data, no step change. So according to this data by Haslam, there's no evidence that ADHD is a natural category. It's just a dimension. And there's not a single study actually now yet. There was a review in 2022. Not a single study suggesting ADHD is a natural category. That's really interesting, and it's the opposite of what we thought for a long time. So there's no natural boundaries in terms of neurobiology that would help us. I mean, the question is, where do you put the threshold? Where do you have your diagnostic threshold when it's a complete continuum, both at the symptom level but also at the causal level? What about impairment? That sounds sensible. Is there a step change in impairment at any point along the severity continuum? So just to showcase one of my recent PhD students, Trini from Aarhus, she looked at this question, and so she tried to explore whether you had a linear relationship between impairment and symptom severity, as shown by that linear line, and no threshold, or a non-linear pattern, which would suggest there was a step change. Oh, you can do this, can you? Ah, great. There was a step change here, so a non-linear pattern. And what did she find? I guess you're already probably guessing. That's pretty linear. No evidence, again, of a threshold that would help us identify what the cutoff should be. In terms of impairment, and that's even more important clinically than the biology probably. No discrete threshold. So, if there's no discrete threshold, and to some extent where you draw the line is kind of arbitrary, what sort of factors affect where people draw the line? Does culture vary? So here's Wendy Chan, just graduated with her PhD, and she worked on a study of comparing Hong Kong to the UK to look at perceptions of ADHD symptoms in Hong Kong and the UK. And so the red line and the red dots, that's the UK, and we're looking at the association between parent ratings and actual activity measured by an actometer on the kids in the laboratory setting. And the green line, greeny-bluey line, that is Hong Kong. And you can see the relationship's very similar, but she looked at the absolute levels of activity. So she took the 80th centile in the UK and then read it across to the activity and then did the obvious thing, read it back to the Hong Kong 93rd centile, same level of activity. And that is a big difference. Nearly all the kids who parents rated as having high ADHD symptoms wouldn't even got into the moderate ADHD in the UK. And this really highlighted for us how culturally determined those definitions of an ADHD symptom are. So I got to move on quickly because I've put too many slides in as usual. So the answer to challenge one is ADHD is a dimension, and the drawing of the clinical boundaries appears arbitrary, though not random, because it's influenced by things like culture. Okay, challenge two. Does motivation play a key role? So, obviously, the key science question from the disorder paradigm is, what is the core dysfunction? So we spent ages, neuroimaging studies, all sorts of studies, trying to identify what the core dysfunction is. And of course, the most eminent researcher in our field, Professor Russell Barke, came up with this model. He argued that based on deficits or dysfunction within it's a very small it's probably not that small up there, that's a frontostriatal pathway that controls inhibitory activity. So his argument is that the core is a deficit in inhibitory control. That's the ability to stop a response once it's started or when somebody tells you to stop. And that leads to a broader pattern of so-called executive dysfunction, like weak planning ability, inflexibility, working memory difficulties. Working memories, that's the sort of holding in mind information, like a telephone number, and then having it there to work on it cognitively, and impaired switching between attentional scenes. So that's sort of Barclay's model. He argued, therefore, it's a very linear, simple, and very saleable model, because it was very successful, and still is. And he argued that this is a necessary and a sufficient condition for ADHD. That is, if you've got this, you've probably got ADHD, and if you've got ADHD, you've got this. Not probably, you definitely got it. And there is lots of evidence, I'm not putting graphs up and all that sort of stuff, but loads of evidence showing a correlation between ADHD and difficulties in these sorts of cognitive skills and links to those brain networks. But those are associations, correlations of a moderate scale, definitely not a necessary or a sufficient condition. But is there another way to look at ADHD? And so what about if we try and actively flip our paradigm rather than waiting it to be shifted by the evidence? And of course we're really good at that as human beings, so we can see here, I think probably Tim Miles probably showed us this in our first year psychology classes, but you all know it. You can either see an old woman with a big nose or a young woman with a small nose, and you can actively switch between the two. And you can do the same with ADHD. You can see it as dysfunction, like Russell does, and the majority of the field, the dominant paradigm, or you can see it as function. So what does that mean? So in terms of dysfunction, that is ADHD symptoms are caused by executive dysfunction, failures of executive function. That's Russell's model. What about this idea, though, that maybe symptoms are functional or rational expression, rational, inverted commas, expressions of the different goals and motivations of people with ADHD. Now, it's amazing that people didn't think of this until we thought of it, because it seemed kind of so obvious. Maybe to me, I don't know. And then to say what are those motivations, we came up with this model, the delay aversion hypothesis. And that is that people with ADHD find delay unusually aversive. I mean, everybody hates delay, but ADHD. And so as rational agents in this model, a kind of economic model, their goal is to try and minimize delay. It's not a maximand, it's sort of a minimand in economic terms. And so the idea is that impulsiveness, inattention and overactivity achieve this minimization of delay. Now, everybody thought it was a completely mad idea when it first came out in the 1990s. But actually, it's proved to have some legs, and it's actually been quite valuable and useful, I think, in terms of understanding ADHD. So you're trying to minimize delay. What do you do? Imagine you're in a situation where you can actually reduce delay. You've got a choice. So what you're going to do, you're going to choose the least delayed option, the most immediate option. And that looks like impulsivity, or can look like impulsivity from a certain perspective. And we know that impulsive choice, the preference of a small immediate over a large delayed reward, is a tendency in ADHD. Multiple studies, various reviews. The one I got there is Mark et al. We did that meta-analysis showing pretty good effect sizes in this preference for the small immediate reward over the large delayed reward. And crucially for the delay aversion paradigm, that effect is twice as strong when you manipulate the experiment so that it actually reduces overall delay rather than maintains the level of delay, which you can do by manipulating post-reward delay, which is something I learned in animal learning in Bangor. So that's that. So delay aversion seems to be quite supported by the literature on impulsive choice. What about where you can't get out of it? This is even more interesting and theoretically was more challenging. But what you can do, of course, is you can change how delay feels. You may not be able to reduce absolute levels of delay, but we know that you can change the way delay feels, and you can speed up the passage of time. And we all do it all the time. And that can look like the hypothesis inattention, overactivity, and disruptive behaviour. Now, that isn't as unlikely as it sounds, because we know that time is a very malleable thing. I always like the chance to get this animation because it's so brilliant. Quite meditative, actually. We all say that what do they say? Time flies when you're having fun. A watch pot never boils. So we know that your attentional focus can change the way time feels. And so it is plausible that things that change the way time feels could be an expression of delay aversion, or shorten and reduce the aversiveness of time. And there's lots of experiments to show this in the general literature. But crucially for ADHD people, we know that ADHD people are more active and inattentive during delay and increases as a function of delay. We know that delay-related inattention, in that first bit, is correlated with people's ratings of how aversive they find delay. Oops, sorry, I hadn't finished yet. And then we know that adding stimulation to a delay period reduces attention and overactivity in ADHD people. So this really, I think, is quite compelling combination of findings. So, but, one step back, do people with ADHD actually feel delay to be aversive? How does the brain react to cues of impending delay? And so we looked at that. And we hypothesized that this brain system, which is kind of the brain system that kind of, the core of it, the amygdala, drives emotional reactions to upsetting events or aversive events. So we, of course, predicted that in ADHD, the emotional brain, those brain regions, would be differentially hyperactivated by cues of delay. So this is Jeroen van Dessel, another PhD student. And together we developed the EDDI. So I was very pleased to have a task that had my name. I did kind of move the words around so that it did come out as EDDI. Anyway, so we had 2 trials in the scanner. We had a cue for a certain delay. This is based on the monetary incentive delay task, but we call it the escape delay task. So we got the one cue is red, then you get a target, you have to respond, you get feedback, and then you have to wait for up to between 2, 6, 14 seconds. So the red cue means you're going to have to wait, no matter how well you do on the task. Blue cue means you're not going to have to wait. So, of course, we contrast the red and the blue cues in ADHD and controls and look to see whether the amygdala was specifically activated. And what did Jeroen find? He found exactly that. So we found that that whole system, including those frontal areas of intermediate prefrontal, dorsolateral prefrontal, as well as more limbic sort of areas, amygdala, temporal pole, anterior insula, were all differentially activated to these cues. And the longer the delay was, 2, 4, 16, was it? Yeah, 2, 4, 16, whatever it was. The longer the delay, the greater the activation. So there was a dose-response relationship. And also, then we ran it for monetary loss, which is very punitive for people, you'd think, aversive stimulation. But actually, the differential effect was only for delay in ADHD. I mean, it doesn't mean they like losing money. It meant that everybody liked losing money. Whereas the delay version was specific to ADHD. So, challenge 2, motivational factors, I do believe, and I think everybody pretty much the field as a whole, apart from Russell, believe that especially motivational factors are key in ADHD. Second, is it singular? I'm moving on quickly. Always struggling for time. So basically, is it a singular thing, or is it a multiple thing, or a heterogeneous thing in terms of the underlying causes? And so we introduced this concept of deep heterogeneity to contrast it with kind of symptom heterogeneity, which is very common in ADHD. There are different presentations, different patterns of comorbidity, but we argued that there isn't a mapping of that heterogeneity at the clinical level with the underlying brain systems. So we call it deep heterogeneity. And the first evidence of this in ADHD was actually a study I did with Mary Salanto and Howard Abacoff in NYU, New York University. And we basically put delay aversion, simple choice task, against an inhibitory control task called a stop signal task, or paradigm, one of them anyway. And that's basically a measure of how efficient you are at stopping when somebody tells you to stop doing something, or once you've initiated the response already. Can you stop? And so what we found was, so this was a great head-to-head. We thought we were going to say which was true. That's what we thought. So we put our task up. Gordon Logan, Russell Shaka, who developed the stop signal, put theirs up. We got the independent people there. And we found out that the two tasks were not correlated. So the choice delay and the stop signal were not the same thing. They were independent of each other. But ADHD people differed from controls on both tasks. And then we were scratching our head, how come this is? Because you're thinking unitary. You're thinking ADHD is a single thing, but it's not. Because based on that, we developed the so-called dual pathway model. So this is basically the Barke pathway, executive dysfunction, and we started thinking about what the biological basis for the delay aversion might be. I haven't got time to go into detail, but it's basically another one of these frontostriatal loops, but it's more ventral, linking into the reward systems that impairs signaling of delayed outcome. This is a hypothesis. Impairs signaling of delayed outcome that leads over time to acquired delay aversion. And then we added another pathway in 2010 beyond the dual pathway model, where we looked at timing in a study with 3 batteries of task timing, inhibitory control, delay aversion. And obviously the timing network is a frontocerebellar network. So that was a sort of the beyond the dual pathway model. And I'm going to leave this bit out actually because I'm running out of time. So ADHD is deeply heterogeneous. And this is now, again, accepted by most people in the field. What about culture? I did want to talk about this because it's very topical. So should the whole concept of disorder just be rejected out of hand? And this, of course, relates to the neurodiversity concept. And it's an interesting concept. It's multifaceted. Obviously, one perspective, it's a self-advocacy movement for neurodivergent people. Started with autism. Obviously, it's been extended to a whole range of other conditions, including ADHD. And the idea is that it promotes a whole range of really good things for people who have been stigmatized and knocked back a lot in history. And, of course, dignity, value, removal of stigma, use of inclusive language, empowerment, self-esteem. In care, get ADHD people involved in the care process more, care decisions, more, and so forth. And also a focus on positive aspects of ADHD, autism, and so forth. This notion of the kind of superpower is the one that's particularly annoying. is the one that people talk about a lot. But I think it's been great because it's had a lot of positive. This formulation has a lot of positive things, I think, about people with ADHD. So a lot of hidden talents are being identified, I think. On a second level, though, it's a deeply ideological position. It's a radical rejection of the concept of disorder. Philosophically underpinned by postmodernism, the notion that it's a kind of a hangover from an outdated way of thinking about individual differences, and also aligned to critical Marxist theory that disorder concept somehow distracts and perpetuates societal attitudes and structures which are oppressive to neurodivergent people. So in this case, you basically switch totally from focusing on the kid to changing society, where probably a more balanced approach would be more realistic, less utopian. But I think there's a third perspective as a scientist, and I think it offers a paradigm flip that could actually invigorate our science. So this is the one you saw before, the notion, the kind of classical conceptual model from the disorder perspective, brain dysfunction, disorder, impairment. So from a neurodiversity perspective, you can flip that model like we flipped from function to dysfunction to function. And of course here you don't talk about disorder, you talk about atypical brain. You don't talk about dysfunction, right? You don't talk about disorder, you talk about different ways of thinking and acting, which, when they come up against neurotypically aligned or non-affirmative environments, create what I call, or what I like to represent as a spiral of decline, in terms of moving from feeling rejected, belittled, undermined, made vulnerable, and eventually very, very, very unhappy, and the consequences of that. So that's the sort of conceptual flip that the neurodiversity paradigm can bring in terms of underlying ontological ideas. So what does that mean for intervention? Of course, you don't focus anymore on fixing the dysfunction. What you focus on is fixing the environment. So you want to align it with neurodivergent traits and make it affirmative. And hopefully through that you create arc of growth and thriving, going from accepted, efficacious, resilient, and so forth. So that flip from focusing on fixing deficits to promoting thriving, I think, is another positive aspect of the thing. Now, it may be that existing interventions already do some of this. Medication probably does some of this. But I do think we can supplement that with new approaches that maybe focus on reducing stigma, creating self-efficacy and agency, and creating resilience in kids with ADHD. Now, I'm going to just give a few more minutes, yeah. So, of course, this flip not only changes the conceptual landscape, it also changes the way you do science. So you go from trying to identify what the core deficit is to trying to understand why outcomes vary as a function of the fit between the person with ADHD and their environment, and obviously to increase the fit. It also promotes a very participatory model of research where neurodivergent people hopefully get put at the centre of the research endeavour. And I'd just like to end by introducing a programme that we're doing at the moment we call it RESTAR, which is Regulating Emotion and Strengthening Adolescent Resilience. And the goal of RESTAR is to understand and ameliorate the risk of depression in people with autism and ADHD, adolescents with autism and ADHD. Because, as you know, it's a group that's at risk for the development of, mental health problems, but particularly depression. And so we've tried to develop a kind of a radical sort of participatory approach where we put our youth researcher panel, and these are all the people. Some people didn't want their photos, so I thought better to put them all the names. So you can see it's a big panel, but they all have a diagnosis of either ADHD or autism or both. And they're right at the centre of our programme. So they're really co-investigators in the research programme. And while that is obviously many challenges come with it, but wonderful outcomes too. So lots of new ideas through that interaction. I haven't got time for all of them. New methods. They've helped us develop new methods using their particular perspectives. New data, so they actually collect data, they do some of the interviewing, which actually changes the whole dynamic of an interview. When an autistic youngster is being interviewed by somebody who is also autistic, and we've got a paper hopefully coming out where we interview all the people in that and ask them their reactions. It's very interesting. And then, of course, new analyses, so they're involved in the qualitative analysis, they're also involved in the neuroscience, so it's not just qualitative stuff, they're also doing the EEG stuff. Very quickly. And they've been absolutely amazing and incredibly industrious in promoting this model. So we've done lots of stuff. We got awarded the Salverson Lecture in 2022, and we tend to do a lot of things jointly. So the academic staff and the young the Y-rappers, as we call them, present together. A lot of outreach. We've done a series of podcasts together about the study. So this is just a sample, loads of stuff. And in fact, they just won an award, something like the National Award for Participatory Research or something. Amazing. They are amazing people. And then lots of events. This is the Being Human Festival, which is like the National Festival for Arts and Humanities. And there was called, that's it, My Emotions and Me, which is one of our work packages, and then Behind the Mask, which they came up with the title. It's a great title. So although the Y-rappers are brilliant, I call these the key stars, because from the team, we've got a big team in this programme, these people have been absolutely unbelievable. And what you need to do this sort of participatory research is the commitment of the researchers in the team. And all these people have been, I just want to mention that they've all been absolutely amazing. So challenge 4, flipping to a divergence paradigm may actually reinvigorate translational science. It's possible. But I'm a scientist and not an ideologue or a politician. So to me, the ultimate test is, will this improve the lives of people with ADHD? Will it lead to a deeper understanding of ADHD so we can develop better interventions? And, I keep holding our feet to the fire on that. So in terms of summaries, I'll wrap up now. The value of the ADHD diagnostic construct is being challenged from many sides. It is part of a matrix of overlapping dimensions rather than a discrete category. Didn't have a chance to talk about the transdiagnostic stuff, autism and so forth. It's psychologically heterogeneous, implicating both motivational and cognitive processes. It can be postnatally determined and have a late onset. I didn't have a time to go into the details on that, but again, we can talk about it. Is operationalized differently in different cultures. Is now regarded by quite a lot of people as a barrier to promoting the rights of people with ADHD. However, my position, I suppose, is a pretty balanced position. It still provides a clinically intuitive framework for effective practice, that whole diagnostic system and the categories it encompasses. And this brings great benefits to people with ADHD. So we've got to be very careful before chucking it all out and trying to replace it with something that's not tested and no matter how plausible it might be, or with what good intentions it might be done. So that's my cautious, I would say, a cautious encouragement to keep considering and try to evolve systems that map better onto the underlying science of ADHD. But it is an interesting paradox and dilemma that the medical practice that works pretty well in getting treatments to patients actually isn't underpinned by the science anymore. And that's a major problem when you want to do translational evidence-based practice. Thank you very much.
That was absolutely fantastic. I hope you agree. We have time for questions.
Yeah.
But for acoustic technical reasons, we'd like to make sure that someone with a microphone has been passed to them. So can we have any hands up there so Ingrid knows where to go to?
There must be some questions.
Well, it's all that delay that you have,
Yeah.
which is hard to...
You can probably guess I hate delay, yeah.
What can I say?
Oh, there's a right at the back, unfortunately.
I am going to regret this because there's lots of people here. However, I work mostly with people with dyslexia, but as you know, there's a big overlap with our groups, and there's lots of conversation about, well, if we change it from a learning difficulty to a difference, which is more positive, we risk losing the support for them. Do you feel there's the same sort of risks in terms of a change, even though it might be a better change in many ways? That, as you said, your main point is we don't want the lives to get worse of people with ADHD.
Yeah, exactly.
Do you think there's a risk with this change that might happen?
Well, I think there is a big risk. I didn't talk about I think the issue about the neurodiversity reinterpretation is that actually there are lots of positives, but there are quite a few negatives, which I didn't talk about. I tend not to talk about them because people tend to get a bit upset. But I do think there's a lot of downsides, and I think one of them, actually not just the support, I think there is a risk of trivialising the impact and impairment that comes with, let's say ADHD, just say ADHD, or dyslexia. So I think that it's not only about the support, I think it's about taking the impact seriously. I think I might regret this too. Maybe we won't put this online, but I do think that one of the biggest problems with the extreme position, the second one I looked at, that very ideological position, is it's a utopian position. And you sacrifice a lot of people's lives in searching for that utopian outcome. And I think, so it's a bit like the medication argument. So people who are very anti-meds, almost willing, if they're happy to stop meds to all people with ADHD from a sort of ideological conviction, but the effect on people's lives would be devastating. But they're almost willing to do that because they want to form this kind of utopian society where meds aren't needed. So I do think that is a big risk in this sort of area. So, but you didn't ask about that, sorry. You asked about more practical things.
No, I think that is what I was asking.
Yeah, okay,
good. As you said, I don't think it's really an open conversation at the moment.
No, it's very interesting.
It's you're one or the other.
Yeah, I did a debate in Brazil recently in is it Salvador? I think it's called Salvador. Yeah, amazing place. And but they were very anti. It was a psychiatry meeting, so to be fair, but the whole room was very sensitized to the downsides of the neurodiversity position. It was very interesting. So I think we should have a debate, like on anything really. We should be allowed to have a debate on these things. But of course, people feel very, very passionate about this. Probably on both sides, but perhaps more on the people who promote the neurodiversity perspective. Thank you. It's a good question. There was another hand just behind you. Oh, you've got your phone.
I'm not stopped. Oh, thank you. Hiya.
Hiya.
Just want to say I'm a qualified staff nurse and I'm finding it difficult with a lot of challenges. I have ASD, ADHD, dyslexia and Nerlens, and as a nurse I find it really difficult to sort of tasks. I'm sort of going from job to job because certain jobs I work well in A&E and I don't work well in a ward or a computer-based job, etc. And I'm finding the stigma, unfortunately, getting worse. Yeah. And I'm feeling I have to keep myself to myself, but it's really hard to be, work in that environment. Do you find the stigma, because you've said that you've gone to work in New York, do you find the stigma sort of worse or similar or better in other countries, or is it more so here, or is it just an individual preference?
That's a good question, actually. I never really thought about that question. I don't know. I'm not sure, actually, to be honest. I think it may be less in America because the diagnosis is so... Let's focus on ADHD. The diagnosis is so common and medication is really... I mean, there are some states in America where I think 15% of kids receive medication for ADHD, which is probably over-diagnosis. But I think kind of what... I do empathise with you, and I think one of the big interesting areas in ADHD and in autism, actually initially in autism, is this whole issue of camouflaging and masking, and it is exhausting. Yeah, very. And but you, in a way, you have to do it. That's the problem. Because
my colleagues, we were different when I was in school, because when I was in school in the 80s, I had the rubber thrown on my head and I was called, you're either, and I don't like the words, but you're either thick or brainy. Those were the categories. As I was growing up, I was struggling a lot, but I was good at some other stuff, but really poor at other things. But as I got older, I was finding it hard to mask it. I don't know if it's a woman thing or hormones added all into one as well. So it's really harder to mask it as we get older.
Yeah, I think you just get sick of masking it as well, to be honest. It's just
but the medications as well have side effects because you're worried, because some of them could be cardiac related, and obviously being a nurse, I know the risks outweighing the benefits as well, so it's really difficult to make that decision.
Oh, you mean with the meds? Yeah. Yeah, I think there are pretty good protocols for monitoring cardiac adverse events. Obviously there's an increase in, these are stimulants, so you get an increase in heart rate and increase in blood pressure is quite common. But I think if you're monitoring it carefully, you're probably... I'm not a clinician, I always have to say that, so I'm not a clinician. But from what I understand and the research we've done, I think it is definitely, with a good regime, monitoring and management and careful titration, I think you're usually okay.
Thank you. I think I'll have to move to America with less stigma then. Thank you.
Yeah. Perhaps that's right. That's an interesting question. I don't know of a study looking at stigma in different countries, which I think would be fascinating. Maybe there is in other areas. I don't know. It might be in intellectual impairment or other autism. There might be something, but not in. I don't think in ADHD. Actually, it's a really good idea to do for a study.
Yeah. For the diagram you showed with the multiple pathways.
Where are we? Oh, sorry. Yeah.
Sorry. Hello.
I thought it was him.
Which of those pathways would fall into the structural and congenital side?
Interesting.
Because you mentioned the adult onset. So I'm assuming, is that one of those three pathways or another one that you postulated?
So, well, I'm glad we got that. So the congenital stuff that I'm interested in, because I had the honour of and the privilege of working with Sir Michael Rutter on the English-Romanian adoptee study, who suffered severe institutional deprivation and very high rates of ADHD and also autism. But ADHD, I think of those who were over 6 months of deprivation, that was 6-month cut-off thing in that study, we had about 35% met the diagnostic criteria for ADHD, 35%. And that was in adulthood. In adolescence, it was slightly less, actually. So it actually got stronger as they got older, the risk for ADHD. So, and that's a really big challenge, I think, to this idea that ADHD has to have this congenital or either. So the risk factors, obviously genetic factors, but also pre and perinatal risks are linked to ADHD as well. So the notion that it could be the result of environmental deprivation is a big challenge for many in the field. Adult onset, again, is a big controversy. So nobody even knew it existed until a big study by the colleagues of mine at King's, I think they've left now, there's Temi Moffat and Avshalom Caspi. They did a study in their cohort in New Zealand, and they found the most, and they do this all the time, they always have these papers that kind of change the field. They're absolutely brilliant. But they found this situation where they assessed ADHD in childhood and then in adulthood. And they found that the persistence of ADHD from childhood to adulthood was very low, about 10%. And the people who had ADHD in adulthood, almost none of them had ADHD in childhood. So this obviously raised a very strange set of findings, but then at least raised the question. And so now I think, long story short, there's been lots of studies, and it looks like there might be, in certain circumstances, people who have a genuine adult onset ADHD. No evidence in childhood, and no obvious trauma, either TBI or, mainly brain trauma. So whether it's induced by an accident or something else. But there is a small group, but it's not definitely the numbers that they were suggesting. It might be a few people. In terms of what pathways, there's no mapping, I don't think. So those people, like other adults with ADHD, will fall into these different... Actually, what I was going to show... can I just show it you? I'll show... where's the... clicker. I was going to show you... I'll just go back. It's not far, honestly. Delay of it. It's actually a good experiment. I'm getting clicking quicker and quicker. Sorry. I'll get there in a minute. Gosh, I've put so much animations in. Here we are. It's getting there. There. So then we look. So this is kind of addresses your point. So obviously, if you've got these multiple pathways and they're discrete, then it kind of suggests they're on pathophysiological or neuropsychological or brain or whatever you call it, subtypes. And this is actually therapeutically could be really important. So this might be a major barrier that if you treat it as one thing, you're never going to target the right system. So here, basically going from Solanto et al., which was the one I showed, down to, and this is only over a 2 or 3 year period, became quite trendy to do these sort of nice little, pie charts, or not pie charts, Venn diagrams. So you can see the proportion of the ADHD sample that met criteria for a neuropsychological subtype. So the red ones are the delay-averse kids who didn't have executive function problems. But there are no real predictors of membership in these things. We haven't found genes that predict, and we haven't found clinical profiles that predict. So these are all combined type profiles. So, and this is the concept of deep heterogeneity, I suppose, that even you've got a combined type profile, the classic ADHD profile, they could be in any of these groups. So, and the other thing, I suppose, the adult ADHD literature, I guess it's not as developed in terms of looking at the underlying biology. In fact, the famous Enigma study, some of you will have heard of the Enigma study, is basically a massive, they call it a mega-analysis. They've got add together samples from lots of massive brain imaging studies of ADHD. And in fact, they split it into adults and kids, and they analyse them separately. And they found actually very subtle effects for kids, no effects for adults on brain structure, which is very interesting. So, yeah. But it is the adult ADHD thing, I think it's a fascinating topic. Thank you.
Hands up for more questions.
There's a lady there. Oh, there.
Right, now is it? Okay, so going back to the sort of heterogeneous sort of pictures.
Yeah.
One of the obstacles I had experience of was quite a strong fixation on ADHD needing to have a paradoxical effect to stimulants. And there were cases...
You mean for a diagnosis?
Yes.
Yeah.
And there were cases where everything else was showing up but the paradoxical effect to stimulants, and so they kept being ruled out.
Yeah.
I think, fortunately, come across where minds have been changed about that. However, when people were tried on stimulants who didn't have the paradoxical effect, it did have an adverse.
Yeah, well,
when we were saying medication, there aren't too many adverse effects, but in that case.
Well, you've raised a really interesting point, I think, in terms of that paradoxical effect. So obviously, you can't diagnose based on the effect of a treatment. That is totally circular. It makes the treatment very effective because everybody who's diagnosed is affected. So that was a fundamental logical problem in the field for a bit. You're right. People said you have to show an effect. But the 2 points I'd just like to make. So, sorry.
It's still, I can't do this. Sorry, can you hear me?
Yeah, I can hear you. But they want it for the recording, I think.
Yeah, I'm afraid some of the local health authorities have definitely not caught up on that at all. They're still very...
Well, there's no what's the word? There's no replacement for good practice. And there are good protocols out there and that they should be using. But the 2 points I'm going to make about medication. The first is dose and overdose. And because everybody has a different, again, I'm not a clinician, just say that. But as I understand it from doing the research, everybody has a different sort of threshold for an effect. And it's very easy for some people to be overdosed. And then you start to see an increase in side effects. So the dose level is really important. The second point is there's very few studies, but the studies by Judith Rappaport in the 1980s, I think, she showed that these drugs were very effective for people who didn't have ADHD, particularly when they're tired, of course. And the amphetamines were used. I mean, they were developed as slimming drugs, many of them, but they were used, I think, like radar operators in the war and so forth used them. So they are very effective there. But the other point is, as you say, about 30% of people don't respond. And no matter, even if you go through the whole protocol in NICE through the different types of drugs, you still don't get a positive response.
Yeah, the unfortunate point from that was that a lot of people were then being ruled out and said, well, you can't have it then.
Yeah.
Everything else is showing up, but you can't.
Yeah.
And that was... I wanted to share that experience.
No, that is really good. Thank you.
Like we were saying there.
Yeah, exactly. If we could find a group there that responded less well, that would be really helpful, because it would also help us focus on which brain systems and which neurochemical systems we might need to focus on to increase the... I mean, the interesting thing is, of course, none of the medications really came out of ADHD science. In fact, ADHD science came out of the medications. Because I think it was just by chance that Bradley, I think it was the 50s, he just thought, I'll try amphetamine on my group of naughty boys in the home I run. And they started to behave. And nobody knew what that drug did, because people didn't know about dopamine in those days, of course. People didn't really understand that. But once we realised those were dopaminergic drugs, then we thought, ADHD must be a dopaminergic condition. So it kind of the reverse translational science in a funny way, but definitely, of course, they're based on the science of neurochemistry, and also the delivery systems are incredibly sophisticated and science-driven. But in terms of ADHD science, I don't think it's had any effect on the interventions, on the medications that are available. It's a bit depressing after 35 years.
There's still quite a few questions out there, so I think there's somebody near the front.
Yeah.
Hi. So I just picked on one of your slides that mentioned building neuroaffirmative environments, creating an arc of growth. And coming from an environment where cases like ADHD and autism is Well, there's growing awareness about it. I could relate with what the nurse mentioned because I did start off young in the corporate environment, but I was not able to pick up with tasks and what was expected of me. Now I'm very interested if there is research or intentions to make research about creating or building neuroaffirmative environments within the corporate system, or sort of collaborating with employers and multinational organizations, HR experts, people managers to understand employees with ADHD and see how they can create an enabling and inclusive environment. I'd like to see research about that.
That's a great question. Do you have anything to do with ADHD Foundation? Does anybody know ADHD Foundation in Liverpool? Because they are a wonderful organisation. They're based, I don't know what they call themselves, but they have a conference every year. And it's a great conference, and they have a great party afterwards, I have to say. But one of the sessions last time was exactly that, ADHD in the corporate world. And there are a lot of companies, at least in that area of the world, who are trying to be more neurodivergent, inclusive, and more affirmative. I think they're kind of driving a blind a bit because, as you say, there isn't much research on what actually constitutes a neurodivergent affirmative environment. I mean, you can think of obvious things like not making ADHD kids just completely sit in their chair all day and not get a chance to move around. That's kind of obvious, but not all schools are even that enlightened. So I'll try and there is even definitely an organisation, but I'm terrible with names. And I'll try and dig out the name, and I'll send it to you, or I can tell you, because I think it's a charity, and its goal is exactly that: to improve the context and the environment for people with, in that case, ADHD, in the work environment, which I think would be great if that could happen. Thank you.
So I think enough time for one or two more questions. Ingrid,
sure.
Is that...
Hello. Hi, I'm just interested, you talked just a little bit earlier, responding to a question about physical trauma, but is your work informed, and is any of this work informed by emotional trauma? Interesting,
yeah. So, obviously our Romanian work is informed by certain concepts of trauma. It's very interesting. So I tend to take my lead from Professor Helen Minnis. I don't know if you know Helen's work in Glasgow. And she's done quite a few studies, and really quite sophisticated studies, like genetically informed studies, so you can control for the kind of ADHD genetic risk. And what she tends to find, so if we talk about trauma, let's talk about maltreatment. That's kind of a specific. Let's talk about physical abuse, which is elevated in people with ADHD as kids. And what she tends to find in her models or in her analysis is that it's the ADHD that actually drives the trauma, the ADHD risk that drives the trauma, rather than traumatic experiences causing the ADHD. Now, that doesn't mean that traumatic experience can't cause ADHD. It just means in the general population, the effects tend to be in that direction. And I guess it's around evocative gene environment patterns and all of those sorts of things. But that's what she argues. In our Romanian study, I guess it was pretty traumatic being in those institutions. But we haven't got measures of trauma, we've just got measures of deprivation. But that clearly is implicated in their ADHD. There's no other real explanation for it. No explanation for 35% of the sample having ADHD. And also we've got genes there, and the genes don't predict. The ADHD genes don't predict ADHD in that sample. So I guess, and I actually did a review with Helen Minnis recently, and we had a big argument because there was that kind of cleaving between physical abuse and deprivation, and they seemed to kind of predict different things. So ADHD seemed to drive physical abuse, deprivation seemed to drive inattention. So they're kind of opposite effects, depending on the sort of exposure you're talking about. So, yeah. Is that full? Good.
Great. Anyone else holding a microphone? Yes, over there, Ingrid.
Hiya.
Sorry. Going back to your delay aversion model, have you done any research on how coupled delayed rewards and punishments are in ADHD? Because I've seen people talk about just how if a reward or a punishment is delayed, it doesn't feel as connected, to the point where impulse spending in ADHD has the money coming out of their account and them getting the cool thing they spent money on are two separate events in their brain. But I don't think I've seen any actual research on it.
So I don't know any research in that very practical, real-world sense, which I think is a great idea. But there's loads of studies looking at what they call reward discounting. And so that's the idea, the value you attach to a delayed reward and how it declines as that reward moves into the future. And there's lots to show that people with ADHD have a steeper, so they lose that value quicker. So it definitely, the laboratory research definitely fits with that experience, I would say. But I think the idea of doing study on actual economic behaviour would be really, really useful and helpful. I was going to say something else, but I think I might have. So in the delay aversion model, that is kind of the first stage. That because of these this one pathway, because of these difficulty or these impairments in the signalling of those future rewards, so the signal, the dopamine signal to those future rewards is less pronounced and gets smaller as they move to the future. Then that is compounded by the fact that they get a lot of negative kickback from their social environment because they're finding it difficult to wait. And it's that creates a sort of dynamic that leads to the acquisition of these negative feelings around delay. And that's why you try and avoid delay, because you know you can't function in those settings. So it's like a kind of, I didn't talk about it because I didn't want to complicate that particular bit, but it's like the idea, the environment compounds the impulsiveness and the delay aversion through that sort of interactive, reciprocal pattern with people's environment. That's the sort of model, anyway, that we try to develop. Thank you.
Okay, I think we have time only for one more question.
You keep saying more and more.
We could stay for a long time, and there is a reward afterwards because there's tea outside.
Oh,
so,
good. No, I don't. I could talk all day, actually.
Indeed, but I think one more question and then we'll call it. Ingrid, who is your person there?
Okay. Oh, I've got you. Yeah.
Hello there. I'm asking a question on behalf of my son, if that's okay. So one of his major challenges is working memory. And is there any significant sort of recognised things that are more effective with working memory? He's going to
no, I think there is. I think, two bits to the answer. Stimulant medication definitely improves working memory. That is definitely true, I think, I say definitely true. The trials suggest that it does. But these working memory trainings, they actually do improve working memory. So I can empathise, by the way. I've got literally no working memory. But so they don't improve ADHD symptoms, but they do definitely improve working memory. So, or at least at the group level. So definitely worth having a look at them. I mean, and you can develop, you have to, the problem, these are commercial things. But you could probably develop your own system, actually, to improve your working memory. The basic system they have, it's all computerized, but you can do it pencil and paper, probably. So they basically increase the working memory load gradually as you improve. So there's this concept in developmental psychology called zone of proximal development. So they try and keep you within your your zone of ability, but just pushing you a little bit more. So that's really what they add to the mix. But you can do that with just memory tasks as long as you kind of gradually increasing the difficulty as your memory gets stronger. And so I would say the research evidence for that sort of approach, it's not a golden bullet. It's not going to make difficulties go away, but it could strengthen your working memory a little bit. Again, just to say, I'm not a clinician. But from the research, I can tell you that. I don't know if that's helpful. Yeah, we can chat afterwards anyway. If you want.
Well, that's a nice segue to the fact that there is tea outside, it's been really wonderful. We could have kept going all night, I think, with questions. I think there's an opportunity now for us to thank what has been a really marvellous evening. Diolch yn fawr iawn, pawb.